One, please start. So we are live.
Good evening, everyone, and welcome to day two of this webinar of a deep dive in GI cancers. Going slightly away from our present schedule due to the vagaries of weather in India, with the rains being what they are, we will first start off with Dr. Sendil's lecture. Now, Dr. Sendil will be speaking upon the role of multi-cancer detection tests in cancers. Now, the reason why we want this to be discussed is these are tests which are coming up in a big way. The statistical analysis needed for this is not the same as that of a phase 3 trial. Are we there yet? Are these tests good enough to be used in private practice today? I think that is the question that is uppermost on all our minds. And that is the thing that I have requested Dr. Sendil to speak upon. And he very kindly agreed to do this educational activity for us. So, Dr. Sendil, sir, over to you for your lecture.
Okay. Good evening, everybody. Vamsi, can you hear me? Can you see me?
Absolutely. Loud and
Very,
clear, and the slides are visible.
very good. Excellent. So, good evening, everybody. Thank you, Vamsi, for asking me to speak on this topic, which is slightly out of the usual things that we discuss in our meetings. So, my topic is titled Multi-Cancer Detection, MCD for short tests. He wanted me to emphasize on colon cancer, but I told him let us widen it a little bit and discuss about its role in cancer today. And the question we are asking is, are we there yet? So let's take a step back and brush up a little bit of our basics as far as screening is concerned. So this is the Wilson-Jugner criteria for population screening. What does it talk about? It talks about two important things. One is the condition for which we are screening relevant? The second, how good is the test? So when you apply these criteria or guideline to the test, you will understand whether a condition is worth screening for and is a test that we are discussing worth using to screen for that particular condition. I don't want to go through all of these criteria, but two important points that I want to make. One is that since we are discussing about tests today, the most important is that it should decrease mortality in the population when you use this for screening. Remember that it should recognize this disease in an early stage, and that early stage detection and treating should result in a decrease in mortality. So that is the purpose of any intervention in medicine, and more so in screening. It's just not enough if you pick up early disease. Applying it to the population, we should be able to show that it will decrease mortality. Now, how do these standard screening tests that are approved for use in practice perform? I wanted to show you these numbers for you to have an idea so that you will compare it with the other tests that I will be discussing today. So you have lung, breast, colorectal, and cervical cancer. These are the diseases for which there are standard approved screening tests. The sensitivity across the board for these tests is anywhere between 65 to 95, which means there is a false negative rate of anywhere between 5 to about 35%. False negative rate of 5 to 35%. The specificity is anywhere between 75 to 95%, which means there is a false positivity rate of 5 to 25%. 5 to 25% false positivity rate. 5 to 35 false negative, that means the subject has the condition, but your test is turning out to be negative. Sensitivity is that. Specificity is false positivity, wherein your test is turning out to be a false positive test. That means the condition is not existing, but your test is saying that this person is positive for that particular condition. So remember these two numbers. What do these pan or multi-cancer early detection tests interrogate? They are looking for certain features of DNA. We don't have the time to go into each of these things that they interrogate. It's broadly looking at differences between normal and abnormal by fragment analysis, methylation patterns, and so on and so forth. But let's come to what they are actually trying to answer. The first question that they are trying to answer is there a cancer or not based on the results of this test? May or may not be there, but that's the question that it's asking first. The second is, if the test comes out to be positive, it also tries to predict what is the site of primary. It'll give you two possible sites of primary. So is there a cancer or not is question number one. If the test ends up being positive, it also tells us what is the tissue of origin or the primary site. Remember that the exercise does not end here. You have to do further imaging. For example, if it says you've got pancreatic cancer, you have to go and do whatever is the standard, if there is one, for early detection of pancreatic cancer. Should it be an endoscopy guided ultrasound? Should it be an MRI? Whatever that test might be. And you will have to confirm that by a biopsy. So just having positivity does not end up being proof of the presence of cancer. You have to do appropriate imaging and biopsy to confirm that particular cancer. Now, let's start with single cancer liquid biopsy screening. That means you're using liquid biopsy to look for one particular cancer. We'll come to multiple cancers in a moment. Now, there are three such tests which have been tested or published. One is for lung, the other is for colorectal, and the third one for liver. Since we are talking about colorectal predominantly, this was published in the New England Journal a year ago. It's called the ECLIPSE study, which looked at Guardant's test called SHIELD and looked at the sensitivity and specificity for colorectal cancer only. Now, over the board, the sensitivity was roughly around 80-85%. But look at the sensitivity for a polyp, adenomatous polyp, it's only about 13%. The sensitivity for stage 1, which is where you want to pick up all these cancers, is 65%, which means there are 35% patients who have stage 1 disease, which ended up being negative on this test. But the sensitivity seems to be very good for stage 2, 3, and 4, 100%. So that's really good, but not at the stage at which we want to pick this up. There's a false positivity rate of 10%, which is what is denoted by a specificity of 90%. That means the test is saying you have cancer, but all these tests that you do end up being negative. Now, what do you do in a situation like that? How frequently do you screen? How frequently do you scope? These are things that we don't have answer for at this point in time. So reasonably good, but not very sensitive in picking up early stage disease. So that you will see is a problem with all of these liquid biopsy screening tests. Now, Vamsi started by saying that the way that these tests are developed are slightly different from, let's say, development of a drug. Now, how do they really develop a test? There are three stages in development of a test like this. The first is called analytical validation. That means you first choose the signals or the biomarkers that you want to use as part of the test to say whether somebody has got cancer or not. And then you validate that in a set of people or specimens with patients who have proven cancer, and then check the sensitivity, specificity of this test. So this is what is called analytical validation. That means you're choosing your biomarkers and putting it to early testing. The next comes clinical validation, where you're trying to do the same thing, retrospective, prospective, whichever way it is, but as a longitudinal study. The question that you're asking in a clinical validation is, does the assay that you have analytically validated accurately identify cancer? The other half is very important, prior to the clinical presentation in serial samples. Because remember, screening is not a one-time test or a procedure. Screening is a procedure where the sensitivity and the specificity get better as you do it repeatedly. So the clinical validation will involve longitudinally or prospectively testing this on patients who are asymptomatic. Now, of the many companies that you see listed on the screen, as you grow up the ladder, the number of companies keep dwindling down progressively. And the clinical utility, now remember we started by saying that the clinical utility should be picking it up early and saving lives in the population. Picking it up early and saving lives in the population. Has the clinical utility been validated so far for any of these tests? And the simple answer is none. So there's analytical validation, using the test on a set of patients to check whether it's working adequately well or not, and then looking at the clinical utility, which is beyond just clinical validation, which is looking at a real life parameter, which is, are we making people or the population live longer? That's the most important question. Now, this is the data on some of the tests that have been put to at least the clinical validation and published. The one on top is the Gallery test. You see that the sensitivity for GI malignancies seems to be overall not bad. But remember, this is for stage 1, 2, 3, and 4. It's not for stage 1 or 2 only. So it's anywhere between 80 to 90%. I put the sensitivity for colorectal cancer. Stage 1 is 45%. That means you will 55% have missed somebody who's already got early colorectal cancer. The cancer seek assay you see on the lower left of your slide. There you see that for ovary and liver cancer, the sensitivity seems to be good. For some sites, colorectum and ovary, you see that the cancer signal origin seems to be good. But as you go down the ladder on to the right, you see that the likelihood of being accurate keeps going down progressively. On the right side of your screen, you see another test called as the Cancer Guard, wherein again for colon and rectum, it's about 65%, for pancreas, about 70%, small intestine low. So broadly, the sensitivity and specificity range from anywhere between about 65 to 80% on the whole. As the stage keeps coming down, the sensitivity keeps coming down. The specificity, which is not shown on this slide, seems to be reasonably high for most of these tests. So false positives are low, false negatives depend upon the stage. The higher the stage, lesser the likelihood of having a false negative test. Now, I'm specifically showing you this test because this is what is likely to be introduced in the country very soon. This is the Guard and Shield test. This is not the colorectal test. This is a multi-cancer test. This has been validated for 9 cancers on a validation cohort of people who are more than 40 years on 814 patients. Now, you are seeing some amount of clinical validation results on your screen. Overall sensitivity again falls in the 60-65% range. Very low for patients with stage 1 and 2 cancers. It's only 34%. As expected, for stage 3 and 4, it's high, obviously, because there's more DNA that is shed in people who have stage 3 and 4 cancer. So the more the DNA, the more is the likelihood that you will pick it up. Specificity is very good. The likelihood of having a false positive test is only 1.5%. The accuracy of predicting the site is also quite good. It's about 93%, decent enough. But what is the important point here? 73% sensitivity in cancers where we have average risk standard of care screening. So we started by saying only 5 cancers where we have standard tests. What about all those cancers where we don't have a standard test at all? We don't screen for them. So the sensitivity to pick up cancers where there isn't a standard test is about 73%. Now, this is across stages. The sensitivity is 74% for the 6 most aggressive cancers, defined as the shortest survival rate. So, it has the ability to pick up cancers that we routinely don't screen for, which I think is a good plus, and a reasonable sensitivity across stages for the most aggressive cancers with a decent prediction rate of about 93%. So that's what is represented a little different in the bar charts on the left lower part of your screen. Overall 60%, ranging from 96% for esophageal and gastric to very low for prostate. The difference is dependent upon the stage. Lower for patients who have early stage, higher for patients who have stage 3 or 4 disease, but that's not uniform across. For example, breast is very low for stage 1 and 2, reasonable for higher stages, and so on and so forth. Prediction is good. So I'm showing you this data because this is what we are likely to have in the near future. Reasonably good. But I think the more important question is this. We spoke about clinical utility. The only test that has been put to check whether there is clinical utility or not is this test called as the Gallery test. Now, this is the largest, first, and the only randomized controlled clinical utility trial of the multi-cancer early detection test till date. Okay. None of the others, all of them have only clinical validation. None of them have been proved to be clinically useful. So far, I'm not saying they are not useful. It has not been proven in a randomized control study, which is typically what you do. What did these fellows, Gallery fellows, do? They tied up with the NHS in the UK, and approximately 1.5 million individuals were invited for the study. 142,000 agreed and were randomized to getting the test every year for 3 consecutive years versus the control population. If you're positive, the NHS took care of the workup and the treatment of that cancer. Now look at the primary endpoint. Think for yourself if this is the primary endpoint that you want to have in a trial like this. The primary endpoint was significant reduction in the incidence rate of late stage cancer. Late stage defined by stage 3 or stage 4 after 3 annual screening rounds. Now remember, we started by saying earlier detection and saving lives. Now the endpoint that they have used here is not early disease, it is advanced disease detection. Is the screened population having a lower incidence of advanced disease? That's the question that they asked. And a pre-specified group of 12 cancers were interrogated. Now let's ask ourselves, is this a validated surrogate for overall survival? Because that's what we want to achieve in the population, because we are looking at applying this test to the population. We'll come to individuals in a moment. It seems to be reasonably good for lung and ovary. There's a correlation between reduction in stage 3 and 4 diagnosis and mortality. Now, a ballpark figure to say that there is good correlation is an R-square coefficient of more than 0.7. You have lung and ovary, that's 0.84 and 0.97. Is there a correlation between reduction in stage 4 diagnosis and mortality? It doesn't exist at all. And you will soon realize why I've shown this parameter separately, stage 4 reduction only. So stage 3 and 4, there seems to be some correlation with mortality reduction for lung and ovary. If it's only stage 4, there is no correlation with any cancer at all. Now, the good thing is that people were quite adherent. 88% were still taking the test on the third year. That means there was a 12% attrition rate, which they had counted for when they did their statistical analysis. Now, let me take you through these numbers. The first one on the left side, after 3 rounds of screening, they did not achieve their primary endpoint, which is significant reduction in the stage 3-4 cancers. In fact, numerically, there were higher stage 3 and 4 cancers in the screened arm compared to the observation arm. The next set of bar diagrams show you what was the result after the first, second, and third round of screening. In the first round, obviously, you pick up latent cancers that have already been there. So there's an increase. But what happens after the first round is that in the next 2 rounds, there is some reduction. So there is a thought that if you keep doing it every year, that this reduction at some point in time might become significant. Now, on the right extreme of your screen, you're seeing what was the reduction or increase in stage 3 or stage 4. The reduction in stage 4 was offset by the increase in the number of stage 3 cancers. Now, remember, I showed you that correlation coefficient for stage 3 cancer reduction, and it clearly showed that there was no correlation. So the study was clearly a negative study. It did not bring down the likelihood of being detected with a stage 3-4 cancer. In fact, numerically, it was higher. And over time, we don't know whether it will become positive. Okay, some slides are missing. Maybe it's good in a way. We will save some time. So the slide that you missed showed the sensitivity, specificity, positive predictive value. The sensitivity was roughly around 45%. The specificity was around 95 or 98%. The positive predictive value was roughly around 54%. So that is the test characteristics, which is not very similar again from the multiple tests that I showed you during the course of this talk. Now, positive predictive value being low is also a bit of a trouble. That means if you have a positive test, the probability that you have a cancer is only 54%. So again, there is a problem there. So if you put the MCED gallery test report card, this is what I would say. Now, if you apply all the rules that we said as far as screening is concerned, the question is cancer an important public health problem? Answer is yes. Is the test acceptable and an accepted treatment exists if you find out cancer? The answer is yes. Are the diagnostic and treatment facilities available if you have a positive MCED test? It needs further workup. What tests have to be done? How frequently should it be done if you have a false positive to begin with? How long should you continue to screen if you have a false positive test is something that we don't know. So I've colored it amber. Recognizable early stage exists. Yes, it does pick up, disease in early stages also. There was an increase in the stage 1, stage 2 pickup also. The slide got missed somehow. But the sensitivity, remember, is lowest in the early stage. It was only around 35% for the gallery test. Is this a suitable test? As I said earlier, the sensitivity is not very high. The specificity is very high. The PPV is around 55%. Performance is below single cancer tests in an early stage. Remember, I told you the Garden Shield test, which was higher than this. The problems are the policy on whom to test, the frequency at which you should test. If you're applying it to the population, what is the cost benefit analysis? We just don't know. It's unclear, unknown. And the most important point is the impact on mortality, which is again clearly unknown for this test at this point in time. So for the question that we started with, are we there? We certainly aren't there yet because we have not ticked all the boxes that you have to satisfy in order to, should I say, satisfy again the criteria that we started this talk. So what are the problems? There might be false reassurance, risks from multiple diagnostic procedures, especially if it's a false positive, though it's very low. Anxiety, like any other test, the diagnosis might come in too late because it seems to be more sensitive only for stage 3 and 4. Financial burden, health disparities might increase, so on and so forth. All the problems of a test like this. So for me to end with, this is giving you or asking more questions than answers. So the first question is, with all these numbers, are these a substitute to standard screening tests or are they complementary? At least we think they might be complementary. I put the screenshot from Guardant's own website. And this is what the American Cancer Society screening website also shows. It clearly says this is not a replacement for diagnostic colonoscopy or for surveillance colonoscopy for high-risk individuals. This is no different than what healthcare clinicians are currently doing with stool-based tests. That means you do the stool test, whether it's your FMT or your stool DNA test, and also do a colonoscopy. Can we use this for the higher risk or specific cancers where the performance is better? Remember, I showed you the Shield test where for some, the sensitivity was very high at nearly 100%. Should we just use it for those? I don't think we have the answer yet. Are there large ongoing randomized control trials with mortality reduction as the endpoint? None that at least I know of. Without randomized controlled trials and unproven surrogate endpoints, is the FDA likely to approve these tests? Very likely. I believe there is a lot of pressure, both from Congress and the public, that the FDA should go and approve these tests for public. So I think it is very likely going to do that because we have fallen back on surrogate endpoints for everything, whether it's an accepted or not accepted surrogate is a different question altogether. But at the end of the day, surrogates are the ones based on which we are going to get approvals. Even though it's an unproven surrogate, there's a high likelihood that the FDA will go and approve these tests. How is the public likely to perceive and react to these tests? They will just jump at it. I don't think they will listen to the statistics, the sensitivity, the specificity, the positive predictive value, and the problems of a test like this. They will end up doing it. We, in fact, had a small taste of this because one company gave us some tests to use. Vamsi also knows about it. It was sold like this in hotcakes, like hotcakes. So this is what is likely to happen. What about us? We are left, in the dark in between the company and people who are taking the test. Do we have a choice? We don't have a choice. If the public demands that the test be there, it will end up being there. And we have to educate public as much as possible and help them navigate to the problems of the test like this so that there's less confusion on both sides and we have an endpoint that all of us are trying to achieve. And hopefully that is mortality. With this, I will stop. Thank you so much, Vamsi, for asking me to do this talk. In case there is time, I'm happy to take some questions.
Fantastic, sir. Thank you so much. And you have done more than what I had asked because this is going to be a burning question for all of us. The test is already launched in India, as you're aware. And
Correct.
the press conference you would have seen where some hospital chains have already started promoting it actively. So I think the biggest question for all of us will be if a patient comes to ask us, should I do the test or not? What should we tell them, in a short line that just go ahead and do it? Or should we say, look, it might help you, may not help you? What's your
I think it is our duty as physicians to educate them when they do this test. It's like educating them about doing a PET scan for surveillance. A lot of our patients come and ask us, doctor, you're not doing as a PET scan at all after breast cancer treatment has been done for localized disease. What do? We try to tell them that we might pick up some nonsense and then go chasing it. So the same thing will apply for this test. Patients will definitely want to have it because it's so easy. I'm hoping that the cost will be high enough that not too many people will want to get it done. But if they want to get it done, I think we are duty bound to navigate through this, help them to go through this confusion and hopefully get some benefit. So we can't
fantastic?
escape.
So, anyone has a question, please feel free to ask. The tech team, is there any way that the audience can also put in a question either in the form of a question box or a chat? Please allow that so that we can have more questions because this is a very interesting lecture and this is going to happen all over the place. There are going to be people who adopt this test wholeheartedly. And like Dr. Sendil says, we have to navigate it in some way or the other. So, anybody has any doubt, please feel free to ask.
Anant wants.
Yeah,
Anant.
yeah.
Yes, Anand.
So thankfully, I heard the last 25 minutes of your lecture, sir, while
Oh, there was
driving.
25 minutes. I exceeded my time.
No,
That's
20
okay.
minutes or
We
so.
allowed it. No
No,
problem.
I was hearing it while driving. So, in case a patient has access to all of these tests, right? I think the one with the maximal data is the Gallery test. I
Correct.
mean, looks like at least the maximum population studied. With its flaws, if you say that I want one test to do, and he's putting you at a gunpoint and saying, I want to do one test. Which one will you do with all its pros and cons?
I think the gallery test, as you rightly pointed out, because that's got the maximum data. You see that the others have just got a few hundred patients' data.
Yeah.
And most of them are clinical validation studies. They're really not big time prospective studies. So the gallery is what we would recommend because that's got the maximum.
Yeah, I think that is something that we can tell our patients that see the one test that has the maximal value is currently not available to us, at least in
Correct.
India. So I think that's something that we can tell them because there's no way around it, as you said. I think,
We
yeah,
have to face this. There is no way
yeah,
around. So Rakesh has asked, where does significant family history fit in? So that's one of the questions, Rakesh. We just don't know. So should we just cone this down to a population of high risk patients so that the sensitivity might improve? I just don't know the answer to that question and whether sensitivity has got anything to do with risk or it's got something to do with only stage. The other thing is that what is the biology of the disease that is picked up by a test like this? Because generally, if it's a ctDNA positive cancer versus a ctDNA negative cancer, irrespective of the stage, patients who have ctDNA that is positive have poorer prognosis compared to patients who have ctDNA stage for stage, irrespective. So do we really know what's the biology of the cancer that is picked up by any one of these tests? Is it going to be different? We just don't have that data also. So in order to improve the pickup rate, increase the sensitivity, possibly one of the things that we can do is to cone it down to a set of high risk patients, just like we do all the other screening tests. We don't run it across the population. We say, okay, if your age is this, if you've got smoking history, this and that, and then you do it. So something like that might improve the results, but I just don't know the answer to that question. Also do it for 3 years, even for gallery. I think that's correct, Sahu, because any screening test improves the outcome when you do it repeatedly, not as a one-time procedure.
Yeah,
So
yeah.
it's
So
doing a
what I meant
mammogram
was
every year.
when a patient comes, we have to tell them that ki do that one test one time is no meaning. And
Right.
even as you told the data, and if I look into it, what is happening is the first year picks up those early, not so-called detected because ctDNA was detecting it. And then the stage 4 comes lesser because you are anyway starting to treat those patients in the first 2 years of getting this thing. So if you do it for a longer time, you are definitely going to see lesser stage 4s. If
Correct.
you continue.
But then the question is that, so let us say stage 4 going down in breast cancer and picking up more stage 3s might have an impact. But stage 4 is growing down and picking up more stage 3s in pancreatic cancer is not going to have an impact.
I understand that.
So we cannot make a blanket statement that if stage 3 is more and stage 4 is less, we are going to include the population,
But
whatever.
the most common cancers you are going to have impact. I don't know. None of us know the answer. But
Might.
as we
We
go,
just really don't know. Lung, maybe, yes, there is some data. Cervical cancer, breast cancer, maybe, yes. So I
gone,
think it
yes.
becomes very, very, it's a very nuanced discussion that you should have. It's something that we cannot generalize at all.
Great.
Perfect. So I think the problem is when people are doing low dose MRIs and low dose CT for generalized screening in a 30-year-old, trying to convince them that don't do a blood test is also going to be very difficult for
Right.
all of
So
us.
I think it's
So
only important that we get ourselves educated and be
Yes.
ready.
Yes.
once
Correct.
you do Ludo's gallery,
Which one?
do Ludo's gallery.
Low dose gallery, please.
Low dose seems to be the flavor of the
Low
season,
dose seems to be.
irrespective of what you're talking about. Whether it's treatment or testing, it's low
It's
dose.
low cost, sir. Low, not low dose.
Low
Whichever way you
cost.
want to look
So,
at
Yeah,
it.
the
no,
problem, Dr.
let me
Vinayak,
get
is if
you.
you gave it low cost, there are going to be 5 labs tomorrow from India claiming that they are doing lower cost test, which we
Correct.
just don't know how good they are. And it is
Just like
happening. It is not new. There are companies who are coming to us and claiming that they're doing blood test testing, and uh, this is going to be a problem. So, like I said,
They come
it's
with a
like our
costly report
NGS
laboratory.
panels.
NGS panels, correct. So I think that was a fantastic lecture, and thank you so much, Dr.
Thanks,
Senthil,
Vamsi.
for educating us. That was a good learning for all of us, and hopefully we'll be in a better position to talk to our patients. So
Hopefully.
next we shall have
Thank
a
you.
panel discussion on the HCC data by Dr. Anant, and his panelists are Dr. Vinayak Maka from Bangalore, MS Ramaiah. We have Dr. Venkat Pradeep Bapu from Tezpur, and Dr. Sumit Goel from RGCI Delhi. So over to you, Anant.
Thank you. Can I just share my screen, please?
Go ahead.
Yeah, okay. Yeah. So good evening, everyone. At the outset, serious apologies to Dr. Vamshi and team for being late. I underestimated Mumbai traffic and overestimated my driving abilities. So sorry. And thank you for inviting me to this. So, unlike the lecture earlier, which was had a lot of masala in it, HCC this time in ESMO as well as ASCO was not so much fun. So what I'll do is I've taken up three studies. Two relate to intermediate HCC, and the third one is with relation to portal vein thrombosis and HCC and tear. And we will have a discussion based on the philosophy of management of these three trials and this intermediate HCC scenario. So the first one is the Emerald 1 study, and this was published 2-3 years back, and the ESMO GI had a OS data output of it, and that's what we'll discuss. So starting off maybe with Dr. Vinayak. maybe 5 years back, it was all about taste, taste, and more taste. What patients do you select for taste plus something, Dr. Vinayak?
Yeah, so I think this is an interesting space. It was easy for us patients to send them without anything, but this space is rapidly changing. Till last 1 year, I used to give only lenvatinib if the patient was convinced. Otherwise, usually taste this happens. They keep on doing one, two, three, and maximum they do that. So lenvatinib was choice, but I think we are spoiled with choice now.
Okay. So, I mean, to go on that one point, you actually feel that taste alone is not enough. You
Yes.
need to add something. Am I right?
Yeah. And second thing is there is response of taste, no? There's no objectivity, proper objectivity that when you do order second one, and there are a lot of things which is in gray area. So there are a lot of rule of seven, something, there are a lot of
Yeah.
parameters which have to be looked closely, but still I am not very comfortable in, our center is not deals with hepatocellular carcinoma at very high volume, but I think that expertise is sometimes find lacking.
Okay. So, Dr. Pradeep, I'll take you one question behind, then one question forward. So the one question behind is, are there a set of patients who are technically classified as intermediate HCC whom you would be comfortable doing only TACE? And the next question is, if you had all options, what would you combine with TACE? So both questions to you.
Right, sir. So the first question I understood you asked is who wouldn't be suitable for the
Yeah.
test?
Yeah, because per se, all these patients would be candidates for TACE plus something. All the patients in the trials, and I'll come to that, like, more than 7, under 7, all of them will be candidates for TACE plus something as long as they're unresectable. But is there a group you would say where, no, I'm okay with TACE alone?
Okay, sir. So ideal candidate book definition of test candidate is the patient who is in a good performance status, intermediate stage, no extrahepatic disease, unilobular disease, multilobular satisfying up to the 7 criteria, no portal vein invasion, and good liver reserve. These are the patients who actually are the ideal patient for the test. So what is the second question? Sorry, I missed it, sir.
The second one is that this ideal candidate for TACE, is there a set of patients you will say, I'm okay with just doing TACE and not adding anything? Or all patients who are taseable, you will continue TACE and add some systemic
Yes, sir.
therapy?
So when we say systemic therapy, mostly with the current trials with the IOs. So IO plus TACE, I haven't used till now, sir, frankly speaking.
Lenvatinib plus
But
TACE?
lenvatinib plus TACE is something which I commonly suggest for the patient. Yes, sir.
Okay. So per se, almost all your patients who are taseable will be getting lenvatinib plus TACE. Am I right?
Yes, sir. Yes, sir.
Okay, fair enough.
Because
Yeah.
in patients, most of the HCC patients I see are from the Nagaland. So in Assam, somehow the place where I practice, the HCC in last 2 years might have I seen only 2 cases. That's it.
Okay.
But in Nagaland, it's a very high incident zone of HCC. So
Oh,
there, we discuss with the gastroenterologist, both due to the alcohol, both due to the virus. So these are the
okay.
etiologies.
Fair enough.
And there we practice taste plus length.
Okay, great. So this is the up to 7, and it very clearly, if you divide it into less than equal to 6, 6 to 12, there is prognostic value. So going forward, so both from what you as well as Dr. Vinayak said, that most patients who are taseable, you will give something. Both of you have more experience with lenvatinib, but if you had access to IO also you will consider, right? So coming to Dr. Sumit then. Dr. Sumit, two questions
Yes,
for
sir.
you.
Yes.
Do you think that combining TACE with IO is manageable? That is one. And two, do you think PFS in this space is a good surrogate for OS?
Okay. So, Dr. Adant, I think you are going to discuss you said you will be talking about Emerald 3. So, we'll come there. So, the first thing, combining taste with IO, is it feasible with manageable side effect profile? So, we need to see what drugs are we combining. So, it is doublet or it is like dual IO, or it's a single IO. So if we are adding dual IO, definitely the side effect that we are seeing, the grade 3, grade 4, they have almost doubled as compared to the taste alone. And there is significant. The second thing is the manageability. The manageability again depends ki what it is a relative term, I'll say. Ki we don't know which organ will be affected, which will be affected. But overall, definitely it will add to the burden in terms of financial toxicity and everything. And again, we need to justify whether is it worth adding to the taste, the IO, and if yes, what in terms of what benefits. The second thing is PFS. Is it a good surrogate for intermediate HCC? For intermediate HCC, we have 4 or 5 studies. Probably all of them have shown PFS advantage. But as the time has passed, because we are just doing taste, and there is no way to access it. Probably after failure, we have something to give, so it has not converted really into the OS advantage. So far, PFS is there, but we don't know. The thing is whether to combine it or to sequence it.
Okay. So I'm going to put you on the spot and say, what do you think about PFS? Is it a good surrogate or not?
For
You have to give me
intermediate,
one answer.
no. For intermediate,
Okay,
no.
fair. Okay, fair enough. So I think that's what a lot of us are feeling, and these are some of the studies. I've shown you only four, and this is the data. If you look at the highlights in green, all of them have shown that PFS improves, right? And if you look at the Emerald 1 data, this is the Emerald 1 data, everyone knows. The curve that kept being repeated was this, that Durva plus Bev, the PFS is 15 months, and with TACE alone, it was 8 months. So on paper, this sounds very impressive because you're almost doubling progression-free survival. But what this ESMO GI said is this. If you look at the overall survival, numerically combining immuno plus BEV is actually less. And as Dr. Sumit said, the SAEs is almost 1.5 times more. So, Dr. Vinayak, your thoughts on this? Doubling of PFS, OS is numerically lower. What is your take on this?
I think OS matters, and even the side effects matters. Most of the times, the PFS, the adverse effect really impacts the PFS eventually. So I would really like to have this data more than the PFS data, because at least I let go of one agents for future or whatever is there. And numeric, we have to look deeply why that kind of response is seen in only in IO combination arm, which is almost comparable to TACE. So I would be really keen that the biology which have worked well is relevant, because I think on the slide you showed that it is low volume also, right?
Yeah, I mean, see, these are better candidates for taste than worse candidates, but by and large, they fit the criteria for taste. So it includes some low volume and some large volume. We had a few patients on Emerald 1 where we really put some large tumors on the study. So they did allow large tumors also. Dr. Venkat, your thoughts on this? Dr. Pradeep?
Yes, sir.
I mean,
So, yes, sir. So in Emerald one, most of the patients, like the intermediate group, when we see the PFS is definitely hopeful, but when we saw OS, the reason the OS got diluted may be due to the better systemic therapies that have been given after the TACE. For example, particularly in the control arm, many of them have received Adjuvant or stride regimen, which might have diluted the OS, and as well as the crossover. And bevacizumab and immune-related side effects are also quite high. So there's a lot of discontinuation rate. I think the discontinuation rates are to the tune of 24% something in the IO arm. So that is where I think the OS got diluted, and that is one takeaway, that maybe in this long surviving patient, waiting for the OS is something we need to do before changing the line of treatment or the practice.
okay. So in your estimation, at least you feel that maybe patients on TACE got better systemic therapy when and if they progressed. That is something that you know we need to look into. And two, maybe Durva Bev, the adverse event profile hampered long-term treatment. That's the sense I get, right?
Yes, sir.
Great. Okay. So, okay, if you had the option to improve outcomes beyond TACE, I'll ask you first and then Dr. Sumit, what would you do? I mean, we know that TACE progression-free survival is only around 6 to 9 months. How would
Yes, sir.
you combine, or what would you do to improve it?
So one of the most important challenge with this is because we are supplying, cutting off the supply of vascular supply, like the post is failure, particularly when we see Indian patients, the stage at which they present, the chance of post is failure is really high because of the either background cirrhosis or due to compromised liver reserve. So when we are combining two drugs, that is the TACE as well as IO, and we are unable to deliver the IO also completely because of the discontinuation rate, side effects. Maybe if we do the sequential thing, TACE first, followed by IO, or giving IO first in a patient who needs, who has a good reserve of the liver, and then doing the TACE as a consultation is something that might, and getting a right patient is the most important thing. Patient selection is really important.
Okay.
And in two emerald trials, trastuzumab, one is lenvatinib. Maybe when we have the final OS data of the emerald 3, um, can we have a better angiogenic partner to be decided for the SCC in the future trials, like lenva versus bev?
Okay.
So that's what I think. So, yes, sir.
Okay. So my sense is you're leaning towards sequencing. That is one, and patient selection. Am I right?
Yes, sir.
Okay. Dr. Sumit, your thoughts on this?
Uh, uh, Dr. Anand, you already answered that. One, Dr. Venkat said we need to preserve the liver function as far as possible so that we are able to preserve the patient and maintain the PS. Second thing, that the 2 points that you said, one is the better selection of the drugs and the sequencing. Sequencing is very important. Again, the patient selection is going to be equally important. We need to clearly select our patients, which are those patients whom we want to combine taste with something. So probably a patient who's got extensive disease, likely to more towards like uh, higher intermediate stage type. Probably I would be tempted to use something, but otherwise, maybe sequential is the better to go at this point of time.
Okay. Yeah, the other thing I think which what Dr. Venkat said was maybe start systemic, put TACE in between as opposed to doing TACE first and then systemic. Maybe that's another way to
Yeah,
go.
yeah, yes. That study
That
is there.
could be
The
one.
ABCHS, HCC, where they are trying to compare taste with the
Yeah,
systemic
yeah,
therapy.
yeah.
It is a web.
Yeah, I'll come to that as well. So, I mean, what the Emerald 3 did was essentially put all the guns in one basket and say, throw the kitchen sink at the tumor. So they gave TACE, lenvatinib, as well as the stride regimen. And usually, more is better, and they hope that this would end up winning. So, at least from a progression-free survival point of view, they did achieve what they wanted to achieve. If you can see the graph here, the PFS was 13 months versus 8 months, and it was statistically significant. And when they did the ITT analysis also, it was significant. It was 13 versus 10 months. But of course, the OS data is immature and it will take some time to get. If you look at the preliminary OS data, it is not very impressive. It's around 39 months with giving everything at one go versus just sequential tastes, and it's around 34 months there. So even adding more therapy to tastes may not be the way to go. So, Dr. Vinayak, is a more conservative approach like just giving lenvatinib first with taste probably an easier option and would conserve patients for IO later? It is
Yeah,
a provocative question, but do you think that is a better option?
I agree with it. The two reasons for it. One is lenvatinib as a systemic therapy option is is becoming very less often used than otherwise. One. Second, IO, you need especially post taste. No, patients are not very comfortable and they don't tolerate so well. So if you're giving Neurogent, I have okay with it. But I think if it is consolidation, I how long to give? See, basically the taste, the intermediate risk is biology is much better than the advanced ones. So irrespective of IO thing, patient will live longer. So I think we have to give for longer duration and they will be prone for side effects. In fact, this regime had a very toxic regimes compared to
Yeah.
the other regimes. The toxicity is too much for that. So patients who are very good PS, we're making actually sick with a lot of IO and other combinations.
I mean, I honestly would be really worried about giving all this at one go to one patient. Lenvatinib and Stride. I mean, individually they are reasonably well tolerated, but to combine everything is, brave to say the
60%.
least.
60% is a toxicity profile.
Yeah, this is the toxicity data here. And, AEs leading to interruption was seen in 84% of patients. Leading to discontinuation is 36%. So these are not small numbers.
Yes.
So, Dr. Pradeep, your thoughts on this? I mean, if you have the fittest of the fittest patient, would you be convinced by this PFS benefit to give this combination to your patient?
No, sir, not really, sir. The reason being, with TACE alone, we are getting a PFS of almost 30 months in most of the trials. So, and we do not have the OS data till, and we have seen how Emerald one went on with such a
Mhm.
PFS benefit also. So, I am really not comfortable. So, as you said, maybe TACE first, followed by IVO, or in a patients with very where TACE may not be suitable, IVO systemic therapy alone. That's what I will go for, sir.
Okay. Yeah, I mean, this is a tough regimen to follow, is my understanding. I think next year mid they're going to get the OS data, so that would be interesting, the mature OS data. So obviously, I think all of you agree that this is probably not practice changing. Major issues with the trial design is that, giving everything at one go will be tough. The other thing is, Dr. Sumit, have you used, I mean, your thoughts on the tolerance with combining, let's say, atezo-bev with TACE or stride with TACE? What has your experience been?
Sir, I've not used personally, but what I see from across the corridor, basically, at Isobar, we all have our learning curve. We know how to use it, how to adjust it, and what to expect. Durva Treme is new and it is expensive. So, Treme being a CTLA, though there is a single dose, so toxicity is there. So, but that is like I have not used it personally, but that is what the impression I get when I discuss with our peer group there.
Okay.
So, so that is one thing. But Durva alone with CTLA4 with TACE, maybe let's wait for the results to come. Then we will maybe we'll discuss again.
Okay. So currently not comfortable. That's the sense I'm getting.
Yes,
Right.
yes, yes.
Yeah, yeah. Fair enough. And this is just some of the data of, the combination side effects. None of them is less than 50%. They're all more than 50% almost. So, I think given that we are getting marginal PFS benefits, suspect OS benefits, and more toxicity, I think it's well worth waiting for more results before we switch to this. I think Dr. Sumit had mentioned this. This is the IKF trial, Atezo-Bev versus TACE. Do you think this is the way to go, Dr. Vinayak? I mean, can you completely exclude TACE? I mean, there are many issues with this study, and this is only an early readout. But what they did was they did show in the early data that if you give Atezo-Bev alone, then they used an endpoint called time to failure of treatment strategy, which was better with Atezo-Bev. If Dr. Sahu was around, he would have many comments on this particular study. But Dr.
It's
Vinayak, your
around.
thoughts?
Is very much here in the thing. I don't
I
mean.
am very much here. So
Yeah.
the so there are stages also. Na?
No, no, I'm not showing them that. Dr. Vinayak, your thoughts on this?
Yeah.
Is there a point in time, let's say for discussion's sake, that this strategy pans out to have an overall survival benefit? Do you think this would be the way to go?
Yeah, I think
Completely leave TACE.
this is eventually the space of the systemic therapy will move forward. That's what we were expecting, because what we're doing in advanced diseases is getting us only few months. So if the biology is the right one to pick, we have patients more than 3 years, 4 years with Atobave. There are biology patients who will do definitely benefit with this combination. Maybe we'll able to dissect it out, but I think TACE is a very difficult for most of centers, because access to TACE is also difficult, and expertise, and there are a lot of multiple TACE that is there. So in that spirit, there is a way, but science wise, it should be better than the TACE, and I would really happy. But because the say TACE has lesser systemic effects as compared to our systemic therapy.
Okay. So you would be actually okay with this strategy if it pans out in the long term. Am I right?
Yes. Yes. Yes.
Okay. Dr. Pradeep, your thoughts on this? This is early data only. The full data is still, will take some time because they're still accruing. You think there will come a point in time when we'll say just give systemic therapy and do away with TACE?
Yes, sir. Might be particularly in the poorly differentiated tumors and those patients who might fare poorly with taste. But regarding
Okay.
the TTFS, because Sahu sir is commenting, I will not make any further comments on that.
You should be scared of him, yeah. Okay, that no. I think what I'm not able to see what Sausa is saying, but there are a lot of nuances in the patient selection as well as the definition of endpoints in this study, which make for good reading. And I personally think that patient selection and then using combination selectively will be better than doing away with one treatment modality, but that's just my thoughts. Uh, Coming to the last bit, um, I'll start with again Dr. Sumit. I mean, see, we have a lot of liver-directed therapies in our armamentarium. We have TACE, we have RT, SBRT. A lot of radiation oncologists are very keen on SBRT and HCC. More and more better techniques are there. So, in your practice, what is your space for TARE?
So tear, actually, we are not very actually, particularly, I'm not very well versed with tear. So my understanding is the patients who are still localized disease but are not candidates for TACE, they go for tear. If finances is not a concern, probably the patients who have major vascular involvement or they have extensive disease, bilobar disease, probably these are the candidates which we discuss, which I think they go for tear in our setup.
Okay. In your institute, or as you see, is there any role for super selective TACE? I mean, in patients who are VP3, VP2, we often hear a lot of our intervention colleagues saying we can do super selective TACE also. Is that a thinking you subscribe to, or in those patients you would rather use TARE?
See, that discussion keeps on coming up. The selective taste. We have been hearing this, but actually, since it does not concern us much, we don't get engaged in that discussion that much. But
Okay.
but yeah,
Per se, I mean, if you see VP3 or something, you are more comfortable with TARE rather than any form of TACE, right?
probably yes.
Yes. Okay. Dr. Vinayak, your thoughts, where do you position TARE? And I mean, any idea of the doses that your IR colleagues are talking of?
So we don't have facility for tear in our center. That makes my life easy. But only thing
Okay.
is the patients who were that there's only subset of patients who have some vascular involvement they try, but I'm not convinced with it, because first of all, I don't have expertise with that kind of thing. But usually they do in a few centers in Bangalore, and it's very difficult to get to them. Otherwise,
Okay.
dose wise, I don't know. That's my
Okay.
beyond my scope.
Maybe I'll ask Dr. Vamshi, if he's, has some time away from organizational this one. What are your indications for TARE? Because you guys do TARE, you guys do SBRT also. So where do you position it?
So if I have to be honest, I think tear will be for the lesions which are around 6 to 8 centimeter, and essentially the indication probably. I mean, to be honest, the radiation oncologist and the IR guys don't sit across the table and decide which goes for one and which goes for the other. That's a
Fair
reality.
enough.
By and large, when it is a PVP4 with a smaller lesion, we are pushing towards SBRT because that's somewhere where the super selective tear and all this is, plus minus. If it is confined to the within the liver, VP1, VP2, tear is a good option there. Regarding the dosing, again, this is a trial which the IR guys keep talking of, the dosisphere. Dosisphere essentially said, boss, you do it properly, you can give more dose to the tumor. That's all. The dosisphere was not actually comparative trial to anything else, but that's their holy grail. So what they're actually looking at is they do this planning. Again, it's a kind of a radiation planning similar to radiation oncology, but much less, I would say, accurate. And I don't think it's as accurate. And they decide how much dose should be given for the liver lesion. And based on that, they will look at how much the rest of the liver has gotten the radiation. And then based on that, they decide if tear can be done or not. So something similar to the liver sparing volume in RT, 700 cc's for the RT guys. These fellows use something called, I think, a 10% dose to the rest of the liver should not exceed certain percentage. That's the condition that they use. So that's where it is done. If patient goes to them and patient can afford it and it is not tasteable, then they would push it for a tear. That's the general indication.
So not tasteable, okay lesions, but VP4, probably you're thinking tear. Fair enough.
For VP4, I'm thinking SBRT.
SBRT, okay.
VP3, VP2, yes, tear is a good option.
Okay. So because, I mean, a lot of us also are not convinced by tear because the earlier data was pretty pathetic. You had survivals of 9 months and 10 months with a very expensive modality. And as you said, the dosisphere is their holy grail, where, personalized dosimetry and you reached close to 2 years. So the reason I brought this study up is because it actually looks at real world data from a very large cohort of patients. This is the proactive study where they looked at close to 1,000 patients. I mean, the overall study was 1250, but they, picked out close to 970 patients with large HCC, and their definition of large HCC is more than 5 centimeters. I'm not sure I agree with that, but that is how they defined it. And 1/3 of their patients had portal vein thrombus. Now, actually, if you look at this patient criteria, only 20%, 5% or so had Child-Pugh B. Most of them had Child-Pugh A. And more than 7 centimeters was around 40%. So it is an in-between group. VP4 was in 10%, VP3 was in 40%. So around 50% of patients had portal vein thrombosis, VP3 and VP4. And if you look at this graph here, it tells us two things. At least that's what the study wanted to say, is that if you go to more than 200 gray and if you go to more than 400 gray, your survivals do start jumping. Now, in a 14 centimeter, I mean, almost a 14 centimeter tumor, if you're able to get around 20 months of survival, that is pretty awesome. And in smaller tumors, you are gaining up to 3 years. So, I mean, that is something that in patients with large tumors or those with primarily portal vein thrombosis is pretty good data if you go higher on dose. The other thing they wanted to say was that even in VP4, which is probably the toughest to treat, if you go to more than 400 gray, you're living close to 1.5 years, and it's almost 2.5 years with VP3. Of course, this is all retrospective data, but what they are saying is that dosing is important, and you can, to some extent, overcome adverse prognostic factors if you give good dose of tear. I'll start with Dr. Pradeep and then the others. Your thoughts on this?
Yes, sir. So as of now, because we do not have consistent OS data, maybe I am not very comfortable combining TACE with IVO. But TACE with IVO, something as you have shown now, sir, the radiobiological and theoretical, it looks really good. And the chance of post-procedure failure, liver failure is less with TACE. So that is something which might enhance the opportunity to use IO for long time with better benefit. And regarding IO alone, yes, definitely in some of the patients who are not testable as per the Asia Pacific as well as the Japanese criteria, maybe those are the patients where starting systemic therapy upfront might be the right goal. But obviously, we definitely need data, as Sahus is saying, in the trial which has compared the systemic versus TACE. Most of the patients who had the types like chelpuxy, and those who actually benefit from systemic therapy are included. So we need good data for this alone, but there is definitely an opportunity to use IO alone. That's what my thoughts.
Okay. Dr. Sumit, I mean, some of the data that I had shown here with TER is pretty good. I mean, with VP3, VP4, if you can get this kind of survivals with a single modality, I mean, would it make you think more in terms of using TER in these patients?
I'm not sure.
Okay.
Hmm.
So you're
No,
not convinced.
no, no.
Okay. Dr. Vinayak, I mean, I
So
understand that
can
you
you tell
don't
me the
have the access to
VC1C,
TER, but
VBC?
isn't some of this data impressive?
Yeah, I think at least for VP3 and more than 5 centimeter, it looks exciting. Uh, in fact, I think systemic therapy is here to stay because the one
Hmm.
option opens up, and we can. You have to be careful selection. That's one thing. And most of the problems with livers, there will be coexisting liver damage or something. We will struggle with that if we give drugs which will again impair the liver reserve. That's two things which we have to look at and enhance more survival.
Okay. So you'll still be
Yeah,
cautious.
maybe I will look at sequencing, not
Okay.
combining.
So, I mean, let's say you have a patient with VP4 and not a very big tumor, and you do tear. You probably would be okay combining IO after tear. Would you be comfortable with that, Dr. Sumit, Dr. Vinay?
Mm, post tear,
I
maybe
know
I
there's
can.
not much
Yeah,
data,
yeah.
but so both of you would be okay combining it.
Yes, maybe yes.
Yeah. I mean, the reason is I feel because if the moment
What
you
is
have
the data
VP3,
of use of immunotherapy post-DARE?
There's no data as yet, sir. It is evolving.
no, there are small studies,
Ah,
but none of them have reached any kind of conclusion or are anywhere close to practice changing. But in
yeah.
practice, when you have VP3 or VP4, you won't want to leave them alone because they are essentially systemic disease. I mean, all cancers are systemic, but they have a greater propensity to spread. So, would you want to wait for it to progress to treat? Was my question. And maybe in practice, we would add IU, is what I feel. Sahusa, you were saying something, sorry?
No, 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 no. I just was looking out for the data for post-DARE, the IO thing.
Yeah,
I
yeah.
expect it to be little better than post-ACE because the liver functions would be much better.
Would be better,
Yes.
yes. I mean, I think of the IO trials, the Ipi-Nivo had 1%, I think VP4. If I'm not wrong. The Atezobev they had VP4. They do not exclude. So, I mean,
And in the Emerald one, they read out the OS this year. Na?
yes,
You
sir,
spoke.
that was the first one I had
Yeah.
discussed.
So, what was the post-progression treatment for the because
Uh,
why I'm asking you this is if you look at the PFS, there was a delta of around 7 to 8 months. It was the
yes,
biggest delta which we saw ever. So just that being just washed out in the survival
yeah.
and totally the curves actually overlapping or little bit numerically inferior for the combination. So there would be something great that's happening post progression to TACE alone. So that's what I wanted to ask. What is the
I,
post treatment of the TACE alone now?
I actually think it's the other way around. I can get back to you on this because I don't have the numbers. I actually think combining treatment options might give you a good PFS, but we are undermining the role of liver decompensation there. If you're combining
Yes,
therapies
yes.
up front, a lot of these patients may not be candidate for second line therapy, which ties into what you are saying. But I don't know the exact numbers. I have no idea of that.
I think, sir, the 70% of the patient post-test received some form of systemic therapy. So that was the one reason they were, as you rightly said, probably their liver function was more preserved, and they
So
were
how
able
many
to.
of them received IO would be a right way how we can probably go ahead.
Yes,
And if
yes.
majority, more than 50%, 60% would have received IO, and this comes out, then this makes a sequencing thought
Yeah,
process much clearer actually.
yeah.
Yes.
It's a better option there. Right. Yeah. So with that, I'm done. I'd like to thank my panelists for a nice discussion and Dr. Sahusa and Vamshi also for their comments. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Anand, for a very, very nicely discussed panelist. And I think the problem is we want to combine, we want to do, but getting across the stakeholders into one trial is, I think, the biggest challenge here. I think, Anand, you might be aware of this new study which people are trying to do with TARE and IO, which, there have been mails back and forth just recalling the protocol. In the last 3 months, they have not yet come out with the protocol. I think that's a big challenge you're going to face always,
Yeah,
because everyone is convinced of their data. If you speak to the IR guys, they're very, very convinced of their TARE data. You speak to the RT guys, they're very comfortable with RT. And obviously, we are very comfortable with the IO. So, to bring all these in a
yeah,
very clear picture and a clear objective criteria, I think it's
yeah.
the
Too
reason
many
why we are
stakeholders not willing to give up
stakeholders.
space. I
Yes,
agree.
yes,
Yeah,
that is a big challenge. So
yeah,
I think that's the major thing. And again, you look at what is happening in the eastern part, Japan, Korea, they actually combine a lot of things together. They don't really wait for these Western large phase 3 trials. A lot of it is on their basis of their own data.
yeah,
And certainly, the way we are doing now, leaning towards is try to combine, for example, even tear with IO, provided you're not getting the RALD, or provided you're able
yeah.
to give it to the patient. I think that's the
Yeah, I mean, their
lesson.
HAIC data is amazing. I
Correct.
mean, they are working on it, they are doing
They are
it,
doing
but yeah,
correct, correct. And HAI for us is kind of difficult. And
yeah,
again, the biggest challenge is, when do you even sequence? We would say don't do a imaging for 3 months, whereas routinely 4 weeks after a TACE or a tear, patients are coming with a CT scan
yes.
or MRI, and then we are struggling to make any sense out of it. So these are challenges. But thank you, Anand, for a very, very nice
Thank
discussion.
you.
We come for the last panel discussion. Dr. TP Sahu sir will be discussing on the colorectal. Again, I'm very happy that all the panels have actually discussed a lot of had a very good discussion, despite the fact that by and large the amount of path breaking data in these conferences this year has not been really so much. There have been good studies, and I thank the moderators for discussing it so well. So, Dr. Sahu, over to you. Your panelists are Dr. Jovita Martin from Adyar Cancer Hospital, Chennai, Rakesh Piniti from Indo-American Hospital, Hyderabad, and Dr. Akash Tiwari from Indore. So, Dr. Sahu, over to you.
Yeah. Thank you, Vamsi. Thank you, Anand, for that lovely discussion. And Sendil, as usual, was brilliant. And every time all of us learn from him. So let us see in the last thing. As Anand told, there is nothing much great also that happened colon cancer, except for two or three things. I even discussed a little bit with Anand. So if he has time, he can stay back and contribute to what he also thinks. Okay. So what I have done is I have actually gone through the 3 hours ASCO recording of the colorectal, and I've thought to pick up what I best felt was would be something that is new and could be practice changing. So that is how it is. So what I've done is first part I will do the ctDNA. It has become more likely discussed and more likely to be discussed in future also. And more the data is, I'm getting more comfortable with it myself. I never used to think ctDNA and never used to think about that. Now I feel a little more confident when I look at the data. And there is little bit of data which was actually published and read out this ASCO. And about ctDNA stage 2, stage 3, I will discuss in the panel that, and then go to the metastatic setting, the BRAF. There was a two data set that came from the BRAF mutation data set. So that I'll discuss. And then if time permits, one important thing which, because it is not a map, we all have forgotten how to use something that is exercise beyond after adjuvant therapy. So I'll talk about that one slide and try to convince the whole Indian medical oncologist to think beyond maps. So this is my whole thing for today. So Akash, I see you and you are near to me in Indore. So I'll ask you a first thing. So 45 years old female, ascending colon cancer, operated T3N0. And 0 out of 14 nodes were there. So nothing as inadequate nodal dissection. What do you normally do in practice? Akash, no high risk, no perforation, no obstruction. I want to rule those things out. Would you just do a capcitabine or a capox or capiri? Or would you do a ctDNA and then decide? Finance is not a concern at all for any of the discussion.
So there's no high risk factors in such patient, and she is MSS. I'll observe these patients.
So you will observe this patient. You would not give this patient any option of anything, even a ctDNA for this patient. Fine.
So no, sir,
It's okay.
not in that.
Okay. It's okay. So, do Rakesh, you also believe the same?
Yes, sir. I think the practice presently, which I'm doing, probably this is a low risk patient for recurrence. Yes, the ctDNA evidence is evolving. If I have to factor in, at least I'll try to prognosticate. But as of now, today, I'm observing these patients.
So, as of now, today you are observing the patient. If it's a T4, would you still just do a chemotherapy, or would you think of adding a ctDNA or thinking something even in T4?
So I think, sir, the circulate data that is again in the ASCO
No, no,
2026
no.
is
I'm not talking about circular data. If it's a T4N0,
so
would you still have?
T3N0.
Yeah.
Yes, sir. I think for now, T3N0, it's observed, and T4N0, we probably look at the hereditary canal, and basically MSI, and if it is MSI high,
It is proficient.
it is proficient. Probably I can give the option of chemotherapy, but I'm more inclined to observation alone.
Okay, you're still in T4, you want to observe. Fine.
Yeah.
Rovita,
So,
any differences? Anything which you want to add, or you concur with both the co-panelists?
Sir, with me, actually, I would, if in a proficient case, I would definitely add capecitabine to err on the
Okay.
side of caution. But if it's deficient, obviously, I'll keep them on observation.
Okay.
But with the data that is coming up, I think eventually my practice will change. I will offer the ctDNA.
So you are in
so
that
sir,
between that the time period where you want to look at and want to look at mature data further. That's what I
Yes, yes, sir.
get from you. Okay.
Definitely.
So what we did was the ctDNA comes positive on week 4. We repeated in week 7. So I don't want to take that thing that we did repeat. Yes, we repeated week 7. And that was negative, let's say, or that was a positive. Either way. One of the data set that is positive is a positive. Akash, now the patient has come to you with a ctDNA report, which is positive and from Signetra. And it is
yes.
a tumor informed. So
So,
would you
so sir,
still
we know that these
observe or would you
patients.
act?
So, sir, we know that these patients who are ctDNA positive, they fare poorly. And if it is done, I would then act on it, sir. I would then
And you
give
will
these
act on it.
patients chemotherapy.
Okay.
Yes, sir.
Rakesh, I believe that would be the same thing.
Yes, sir. I think I would probably offer
Okay.
chemotherapy, capecitabine. Yeah.
Okay. So now I go to the main concern, main thing which was read out this ASCO. So there is a, let's say this is a stage 3 or stage 2. At this point, let's assume it is a stage 3. I put it at stage T3 and 1. And this patient was positive, and we did give a chemotherapy, and the ctDNA was positive. So would any one of you want to repeat a ctDNA mid-cycle at 3 months after 3 months of treatment is over? Uh, do you think if you start off and the patient is aware, is well funded, has deep pockets, wants to take the therapy but does not want to take anything extra, he wants or she wants to follow the latest science, would you like to do the 6 months of the protocol for a stage 3, T3 and 1? Or would you just stop at 3 months and not do anything because it is typically the lower risk of the stage 3s? Or would you do something and then act? Hope my question is clear to all the three panelists.
Yes. Sir, I think I would wait until I
Mm.
finish the chemotherapy and then
Okay,
I'll
you
act
will wait.
doing
Okay,
the.
done. Akash, any difference in opinion?
So, so sir, I'll finish with the chemotherapy if there is no neuropathy.
6 months.
And sir, but I'll repeat ctDNA. Though it was done at baseline, then I'll follow up with ctDNA.
So you will repeat it post 6 months.
Sir, so third month and then three months.
So third
That way,
month,
sir.
the ctDNA is negative. You repeated it, it's negative.
So, sir, my usual practice is these patients develop neuropathy. I tend to stop oxaliplatin. We have evidence of in T3N1 giving only 3 months
So
of
you want to give only
Capox. So
capecitabine
I
in that
think that
case.
is so. Anyways, also, sir, in T3-1 there is evidence of giving 3 months of
Agreed.
Capox.
Agreed.
So
And
I
let's say
would
the
be inclined, sir.
indication was 6 months.
Sir, I
Akash,
would finish with I would
you would
finish with
finish.
the 6 months, sir.
Okay, done.
So,
Rakesh, any
sir,
difference?
I would like to put in that I will use the ctDNA data at least when I'm iffy to use it, but would not change decisions
So
significantly based on
basically,
that. So, for
what you are telling
example,
is, yeah,
a
tell me please.
T4 a T4N0 ctDNA negative in my practice would still receive chemotherapy. Uh, if it is MSS. So that way, sir. If clinical parameter wise these patients are so usually I don't would not get it done. But if it is done and the patient is otherwise say somebody is DPD intermediate metabolizer, That is where if it is ctDNA negative, I
I
am
got it.
also a
So
little
basically,
iffy.
you're
Somebody
looking at
has
the
a
toxicity
coronary artery
profile.
disease. That
You're
ways
looking
I
at the
would be okay
toxicity
in
profile
acting.
more than the efficacy part of it.
In that way, I would use a ctDNA report to make a decision. But if otherwise the patient is fit, especially in high risk groups like a T4N0 disease, for a ctDNA negative, I won't stop. So that way, sir.
Anand, you're there? Anand?
Yes, sir, I'm here.
Yeah. So I have a T4N1. Patient is ctDNA positive, has done it. I understand stage 3 one would not do it, but they did it. So now the patient is ctDNA positive or a stage 2 high risk T4N0. In the patient, you intended to give 6 months of treatment. And then the patient is having 3 months. Would you repeat yes, no in such a
Yes,
case where you have scheduled your treatment for 6 months?
I would repeat it for
Okay.
sure.
And if it is negative, does your things change or
No,
does it not
no,
change?
no. Because
Okay.
very clearly, this kind of patients will track into three groups: negative,
Mhm.
who will remain negative;
Yes.
positive, who will go to negative; positive, who will remain positive. Right?
Yes.
So we
Yes.
do know that even if positive comes to negative, a sustained negative will be better than one who turns back. So I would want
Okay.
to track at all three time points. That's
Okay.
my thinking.
So as I get it from on the panel, that yes, they if they've done once at 3 months, they would do it. But if it is negative, they'll be pretty happy. If it is positive, you anyway won't change. Only prognosticate the patient. You won't change chemotherapy at this point of time. Okay.
So may I
So
ask
now,
a question in this
yeah, please.
setting? When we have a stage 3, when we see that it's positive ctDNA, wouldn't we want to escalate it to a triple agent instead of capox,
So actually, I didn't want to
FOLFIRINOX?
bring it because it was already tested and it is actually not shown to be beneficial. Actually, the de-escalation was also marginally missed its margin actually. Just missed it, the non-inferiority margin. So at de-escalation, if there is a very elderly T3 N1, probably you can still argue, but escalation, no at this point. And there is a clear data set for it published actually in last 1 to 2 years.
At least
Okay,
escalation with chemotherapy. Let's put it that
escalation
way.
chemotherapy. So people are thinking, should we add a biological? That is the only way, but we don't have data for that. So I think Anant was pointing towards that. Okay, so this is the dynamic. I'm not going to do much about it. We had a debate yesterday last time. The important which I wanted has been highlighted by most of the panel discussion done before. Please choose your panel very carefully. The platform is very important. And if you look at it and look at the sensitivity and specificity I just brought out from the dynamic data set, and if you look at this part of it, and just look at if you do a whole exome sequencing versus the CRC panel, even from the same signature, when they did it and tried it in a post-hoc analysis from the dynamic 2, when they looked at more genomic signatures, they actually, if you look at the WS informed, had more specificity and sensitivity, which is very clearly mentioned here. So what I meant to say is, please, the platform is important and you have to look into when you're going to decide treatment. For what Jovita was speaking, this is that data set which was speaking of the escalation, de-escalation. And actually, if you see, this did not actually matter and the de-escalation failed. Sorry, escalation definitely failed. De-escalation missed the margin by just a few points. So this is the data set which I wanted to show you, and then we will go ahead and discuss what exactly is it practice changing, if not why. This is a retrospective data set. So first negative point, it is not a prospective data set. And this is from the Circulate Japan Galaxy study. This included every patient from stage 1 to stage 4. And they took the pre-chemotherapy baseline thing that was between 14, post 14 days, and that could be before that chemotherapy was started. And they divided it into the long adjuvant chemotherapy and the short, more than 90 days and less than 90 days was the cutoff for the adjuvant to be told long or short. So at the 3 months, at 90 days, they did one more ctDNA. And they wanted to see if you stopped, does it matter? Or if you had a ctDNA negative and you continued, does it add anything more? That was the basic thing on how the study was performed. Look at it, most of them were T3, T4s, and it was majorly a nodes positive study. So this is the two data. This is the two things which I wanted to highlight. All of us know the earlier the ctDNA clearance, better it is. That's already done. This is very important for people to remember that what it showed is if you have a long chemotherapy that is beyond 9 months, you had more of these patients who were having clearance, decreased and but detectable was still there, and the chances of rising were very less. But the short chemotherapy, more less than 90, in that group which was there, stage mainly T3, T4s and node positive, if you do the short chemotherapy in those, you had lot many patients who were actually having a rising ctDNA. So this is one part of it. This comes no benefit in longer chemotherapy in patient with ctDNA clearance after 3 months. This is the data set which was read out with its retrospective point being made very clearly by the author at that point of time. And this is what it was all about, which Anant was speaking about the four types. It is a sustained negative, it's a clearance, it's a decrease by detectable or rising. That's well done. So now with this data set, Akash, any thoughts that even in a stage 3, at 3 months, if you do it, would you stop it for a small segment or you do want a prospective data set to look at it? Because the data set has some power to it. I'm not telling it's conclusive, but I felt this was something which was new to stop at 3 months and look at it. Does it have a more relapses actually? Akash, quickly. You are muted, Akash. You are muted.
How I use this data as an idea data is कि if so I would be okay in stopping at 3 months, especially in patients who are having these some sense of neuropathy, so initial signals. Otherwise, would continue 6 months. So that is how I
Okay.
use it.
So you would
Uh,
not change.
in T4 especially, sir. So T3 N0 two risk factors positive, and that is why we are giving chemo, or one risk factor we are giving chemo, not in that group. But say a
Okay.
T4 disease, I would prefer to finish the whole 6 months.
Rakesh, any change, any thoughts, or would you still go and
Yes,
read
sir.
this paper out, or have you thought, it is done, I will still continue my treatment, or only stop it for those who have a significant toxicity, have some data to back it up?
So let me again, sir, the dynamic has shown that it is a good prognostic marker. And this data set is suggesting that it could be a predictive marker when we compare it with the pre and post midway chemotherapy. So for somebody who has remained initial ctDNA positive, I'll probably continue as tolerated till 6 months. But if it is negative midway, probably I can drop off chemotherapy, especially when there are toxicities, like Dr. Tiwari was saying. But if somebody has remained negative upfront and remained negative in the midway also, they have good prognosis. Probably if somebody has started chemotherapy, I have no hesitation to stop chemotherapy. And so somebody who is remaining positive, but there is a decreasing trend, I wouldn't escalate beyond 6 months as of now.
Anant, any thought process of a patient apart from toxicity, which you think a ctDNA, this data set is coming and it shows that there's a flattening. Actually, the censoring part we can speak some other day, but there are quite some decent numbers, and this is actually flattening as we see the ctDNA being negative at 3 months, and this data is looking good. But definitely there are flaws to this data. I know that. So, Ud, what is your take on the practice?
So, I think the way what in my head, my policy is to divide it into the low risk and high risk for stage 3.
Yeah.
If you end up being negative at 3 months, if you do it, then obviously I'm super happy. If it is high risk stage 3, I still have my reservations. There are
Stage
data
3, high
sets,
risk stage 3, ctDNA negative. 3 months.
ctDNA negative after 3 months.
Yeah.
I have my reservations. So I would
Okay.
want to complete 6 months.
Okay. So if there is a prospective data set, then you think it would be practice changing, and that
Yes,
is the
yes,
only
for
thought.
sure.
So why I brought this up is this is something that I felt was little new. It was read out. It has its own fallacies, but yes, if you have a prospective, which we expect in next year or so, two data set to be read out. One that come out, the whole gambit of 10 trials, once you is going to sit together, I think this is the future. Not yet there, but this does give us some data set evidence that if there's a toxicity, at least we can discuss this data set with the patient, we'll stop it. So this is what I felt, but most important for me, technique and platform. is important. Just any cheap lab would not do, especially for adjuvant treatment. We have to probably go to the standard platforms. Okay, Dr. Jovita, I'll come to you first on this. 36 years old male, colon cancer, de novo liver metastasis, RAS wild, BRAF V600E mutated, HER2 negative, proficient MMR. How would you treat this patient? I given the options to you. You can choose anything else what you would like to.
Okay, I think the breakwater trial with encorafenib will be
Yeah,
the right
definitely.
choice,
Yeah.
sir. Yeah, but in practical, for practical purposes, encorafenib is not really that accessible, sir. So in those
We
cases, I'm
expect that every drug is accessible.
okay. If it's accessible, fine. Otherwise, we tend to have a lot of issues in procuring the drug. That is one thing, sir. And there's also another doubt that I actually wanted to clarify. When you said that, you do an intermediate, testing for a ctDNA and you find out that it is negative, would you want to stop it? My thought process is like this, sir. Normally, if something gets negative, you consolidate, like for gestational trophoblastic neoplasm and things like that. You consolidate two more cycles
Two more
after it becomes
doses.
negative.
So
So
two
could
more doses of chemotherapy and
yeah,
then
yeah,
stop.
something like that. Would we be able to? Though that way, we will have a deeper molecular remission, like how we see in hematological malignancy. So
Actually, to be fair to the ctDNA part of it, another one is a tumor marker. This is a ctDNA much more deeper and deep
Yeah,
than
this
a
is the
tumor marker.
deepest of the deepest.
Yeah.
Right?
So whether it will be just a spelling of a chemotherapy or two more doses, I really don't know. But yes, we are here doing the ctDNA to the site. Here at this point, I totally take your everyone's point. It's prognostic for sure, predictive for a very select few. And all of the clinicians, even in the Western world, are not very sure of. There is a divide even in the Western world, whether it's a predictive marker or not as of now. In the next 2 years, I'm sure this question will be answered with two large trials will be read out. So coming to this, Jovita, you told was a get from you. If it is there, you would be more than happy to give encorafenib with cetuximab with the chemotherapy. What is the chemotherapy of choice? Is it FOLFIRI or FOLFOX, or is that to be only FOLFOX?
I think I would choose FOLFIRI, sir.
You will choose FOLFIRI. Okay. Let's see. Anand had the winch in his face. I will ask him the last. I will ask now Rakesh. Rakesh, quickly. The cetuximab and encorafenib data is settled. In such a patient, if affordability is not a cost, the drug is there. Would you like to give it? That is the settled issue now in front line.
Yes, sir. I think now we have a cohort 3 data also. FOLFIRI or FOLFOX doesn't matter. I think cetuximab plus encorafenib is going to add a lot of PFS to the patients.
Okay, I'll take you one step further. If you look at it, if you want the cetuximab and encorafenib, the data set, as we look when I talk of the later stage use of cetuximab and encorafenib, these are actually these type of patients are CMS1 type, which are actually more likely to be immune responsive.
Yes.
So would you love to do a nivolumab or an immune checkpoint frontline with this, or is it still too much to handle?
So I think this is proficient MMR. I think clean
Yeah,
BRAF
it's
mutated.
proficient. It's proficient. It's
Yes,
totally
sir.
proficient. So you would not like to use it.
I would
That's what
not
I
as
get
of
from.
now. Yeah.
Akash, any thoughts
So
regarding
first on
Folfox,
chemo,
Folfiri? Rakesh told
the
very
rituximab
comfortable
plus
with anything.
encorafenib and either of the chemo depending upon the toxicity profile. Sir, as far as your
Okay.
question on addition of IO is concerned, sir, we know that there are certain preclinical trial data which were very encouraging. Some of these patients did very well. They had this
Mhm.
hypothesis that it converts it to functional MSI high. But sir, in
Yes.
absence of and the second line data was not that successful. So, sir, in that view, I would not add immunotherapy in upfront settings.
Anant, quickly, Folfox versus Folfiri. All of us agree cetuximab and encorafenib should be the drug of choice as a target. Folfox plus Folfiri, Rakesh speaks that both are equal. Akash also felt the same. Jovita goes towards Folfiri. What is your go-to drug?
Yeah, so the only thing favoring Folfox to me is that after 4 to 6 months, you can drop a drug off because you will not continue oxaliplatin beyond 6 months, and that might lead to a slightly lesser side effect profile. Otherwise, as all of them said, I think the annals paper clearly said that,
Yeah,
they are
so, and
equivalent.
actually, there was a little bit of criticism, a little bit of fear for use of irinotecan in this subset patient initially, which was thought to be the drug interaction and the cytochrome P50 thing, which was
Yes.
actually later on proven to be not so much. So if you look at it, although there is a data set, but the randomized data set is for Folfox, the cohort 3 was read out for Folfiri. So people have to remember, still the Folfox remain the standard of care. Folfiri more so can be given because of this data set being read out. And this is very important for when I look at the comparative, this is the PFS, very nicely read, spread out data curves for the PFS. Every subset nearly goes through. Even the OS was also significant here, although the separation happened well beyond 6 months. So from the 4 to 6 months that separation happens, it is well sustained. And if you look at even 18 months, if you see from 73 in each arm, 50 still go on, are there at risk, even in the AC for plus Folfiri. Only one criticism for me, if you look at the control, it was Folfox, it was a Folfiri or chemotherapy plus minus the bevacizumab. And this, all of us believe that bevacizumab should be given in all. But to be fair to the trialist, I went through the author did not read out this data, but when I googled it, you did find that bevacizumab was given in 85% of patient in the control, which is a fair number. In 85% receive bev plus the chemotherapy gives us a very good thing that okay, this drug, this trial is a positive trial. This cohort is a positive cohort. This is the two data set actually. And if people are there, they should look into this. The response rates are typically there. It is around 60-62% for both Folfiri with EC, the encorafenib and the cetuximab. The PFS is again positive for both. And the OS, if you look at it, is doubling with addition of EC. And actually in the cohort 3, which is Folfiri, it was not reached, but we can tell that the hazards is same for both 0.49 to 0.56. So this part I want to conclude. Yes, the panelists were right. We have to use chemotherapy as Anand told. That is what even the discussant spoke about it. That this trial gives us a data set that you have to continue with encorafenib and cetuximab. And you can de-escalate to fluoropyrimidines alone after a particular thing. So that gives the data set in favor of Folfox. But if someone uses Folfiri, he or she is not incorrect. But we are aware of the toxicities. This was what Akash was speaking. Joita, again, you missed out giving EC or encorafenib in front line. Would you give it in second line and add nivolumab? Why I'm talking about this is the MD Anderson data set. And if you look at it, if they added PD-1 inhibitors in second or third line with a small number of 26, the response rate was actually 46% with a median PFS of 7.4 and the OS of 22 months. Astonishing. So this was the data set based on which the group went ahead and this randomized trial, the SWOG trial, which is encorafenib cetuximab nivo versus encorafenib cetuximab, a very clear-cut randomized, a small data set, 2:1 randomization in favor of nivolumab. So what do you think? This is a positive or a negative one?
A very encouraging one, sir. I think I would also, keep this
No,
in
no, please
mind and
don't do
whenever
that.
possible.
It has been read out, and actually, Akash told about that. The OS is
Sahu
negative.
sir, you cannot do this. This is so mean.
No, I'm not mean. So I just TF is also negative. What in ASCO, I felt more than hearing out the reading out a paper. One should always look into the discussion slides and listen to the discussion. You find more information and a holistic knowledge there. What actually happened in the question answer when it was asked to the authors? The authors did speak from the primary student MD. I understand that they were a little surprised by this result, but this is what the result is. They told that we are so sure of this data of ours that even few of the patients are surviving beyond 3 to 4 years. We are going to molecularly look into this data set, which are these patients which are surviving more, and then we will relook at the data set again. So what I meant to say is this data set is not died down. Yes, for us, not doing trials, it was done. But what they wanted to say is there is a segment of patients who are proficient MMR, who are this BRAF mutant, and they think in second line addition of PDL1 matters. but they are not sure, and it is not for all comers. I think this part is done. Rakesh,
साहू सर,
quickly.
आप
Yeah.
मेरे से आप मेरे से सेकंड लाइन का पूछते तो मैं हाँ बोल देता सर, न्यू एडिशन में। मैं सर
चलो तो at least someone was
that
honest enough. देखो Anand,
no
see this.
not we are aware of this evidence, but sir I think their preclinical data looks so encouraging. So I think that there will be some patients who will live very long in this trial also
So
with their
Akash,
follow-up.
I think we
I,
should not do it. And if not, this the point that trial is read out. And we look at
no,
exactly the
I-
PFS
just
response rate.
just kidding sir,
Yeah,
just
yeah.
kidding
OS,
sir.
everything is negative. If you do it, please do it on a consent properly taken. Okay. Rakesh, quickly. Do you believe in non-operative management for rectum?
Yes, sir.
Very good. So now a patient comes to you, has achieved a CCR,
Yeah.
and the patient is only with immunotherapy or immunotherapy-based treatment. So after the patient achieved a CCR, would you do a maintenance immunotherapy protocol or would you stop? And is there any evidence for that?
So optimal duration
I,
of
I, I,
immunotherapy.
I hope you have got my question. The patient has achieved what you intended to have a CCR. When you have
Yeah.
followed all protocols and patient is ready to do a good follow-up as
Yeah.
scheduled, would you like to stop immunotherapy at this point or would you give a maintenance?
I'll probably stop, sir.
You would probably. Are you sure?
I'm not sure. That's what I'm saying, sir. I'll probably stop.
Probably. Okay.
I'll wait
Joita,
for
yeah,
others
you
to
will wait
comment.
for
Yeah.
what?
I will probably wait for other comments. I won't comment because I don't have data to suggest either way.
Jovita, any thoughts on this patient profile?
Sir,
Fresh.
honestly
Yeah.
speaking, without going surgery, I'm not comfortable.
Okay.
Second is, without giving a maintenance, I'm definitely not happy.
So you want to operate even and don't believe in the concept of NOM, point one, which I get from you. Fair enough.
Yes.
And you believe that if you're doing NOM, you would not stop immunotherapy. Akash, your thoughts on these two things. Do you believe in NOM?
So MSI high, yes sir, MSI high 6 months
Yeah,
sir.
yeah. 6 months. And if they achieve a CCR, you will stop.
6 months and stop sir,
Okay.
and follow.
Anand, do you stop it in your practice as of now? The Nostali data set you leave apart. It was a very short, all of us know. Apart from that, do you continue immunotherapy even you achieved a CCR?
No. 6 months, and till we had dostarlimab, we used Pembro and Nivo, and that's what we are doing. We are stopping at 6 months if there is CR.
Okay. So the Chinese read out this in this paper, and they actually told two things which Anant is speaking. And definitely, I think there are institutes like ADR which does believe that surgery is still done, but I think most of the world has shifted towards NOM, and they believe in the NOM thing. But uh, doing maintenance has not added anything. What they read out and actually wanted to tell is what Anant and Akash spoke about. Do this. If you achieve a CCR, follow the patient as per protocol. There is no benefit of adding any immunotherapy post you achieve a CCR. Quickly, Akash, episode 3 was read out, but I want to speak of, do you use aspirin in your practice for a colorectal cancer? We had this data set with a specific mutational subtype. So do you think that all comers would have also benefited?
Someone should use, but I don't. Matlab, the question is if I use, I don't, sir. Matlab, I
Okay,
don't
do
know
you
about
don't
that.
even test for it? The the PIC3.
So, sir, we are not doing it, sir.
Okay, no fine.
Matlab, we
Jovita,
should, we are not doing it. So, matlab.
okay, Jovita, do you do a PIC3 for your colon cancers and colorectal cancers? Point one. And do you think that you or you do want to do aspirin irrespective of PIC3?
I think I will do aspirin irrespective of PIC3.
Anand, you will beat me after this. And Rakesh, what is your take?
So we're not testing PIC3.
Okay. So if you're not testing PIC3, are you adding aspirin?
Not yet, sir. We are not adding
Okay.
aspirin. We are not
So
testing PIC3.
quickly, I tell you, don't add aspirin as of now. The episode 3, the subgroup analysis has not been done. They have not done the molecular subpart of it, but on a trial setting, they wanted to give adjuvant chemo plus placebo for 3 years or adjuvant chemo plus aspirin 100. The PIC3 trial had actually 160 milligram aspirin. So decently high dose, but all sudden this has a much lower dose. The trial was negative. So at this point, we should only add aspirin if you're doing the molecular based treatment of adding a aspirin, 160 milligrams. This trial 100. The last thing which I wanted to discuss before I stop is the structured exercise after adjuvant chemotherapy. Any one of you have read this paper? Hi, Akash, hi, bol do usko.
Hi, sir. So sorry, sir, ma'am.
Okay, no problem, no problem. Please, 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 no issues. So, any one of you has read this paper, has started practicing the structured exercise after adjuvant chemotherapy colon cancer? Vamsi, have you done that?
Yeah, yes, sir. We practice, sir.
You practice it?
Yes, sir.
Wow.
Sir,
Okay.
we
Now,
advise
Akash,
it to all our patients, sir.
I'll ask you something.
Yes,
Anand,
sir.
do you practice it?
That's awesome that Dr. Akash is doing it because it was a very difficult program.
No, no, no.
When
Hold on. I'm going to ask him. I'm going to ask him. Is he practicing? So,
Yes,
Akash,
sir.
how do you do that? It's important
Sir,
because
so,
this was,
sir,
yeah, please
sir,
tell
so
me.
we, sir, the target that these patients had to retain met would take, sir, around 60 minutes of walk a day or a 30 minute of cycling. So we would ask our patients to do a morning exercise and walk daily, record it, and ask them on a next follow-up visit. Would ask them to do some form of strength training. Of course, sir, some of them will miss out, but a constant encouragement
So
and
for how
telling
long
them
have
that
you
this will
done that?
improve your
So for how
survival.
long do you ask them to do that? For how long?
So a 60-minute brisk walk or
I
a
understand.
30-minute cycling,
For how much of duration?
six
6 months, 1 year?
6 days, 6 days a week, and we
For how
ask
long?
them to do make it as a
Okay,
practice for their life.
Malab, don't stop it. It's good
Don't
practice.
stop it.
Okay.
So we know
Rakesh,
that, sir, such
Yes, sir.
aerobic exercises would reduce non-cancer deaths also. So
Rakesh,
Sir, I have basically kind of explained them to meet around 10,000 steps per day. I have not asked them to do a specific brisk walking or aerobic sort of exercise. It is a structured exercise program. I've gone through the protocol. It looks
okay,
very
I'll tell you what it is, why it is not, it is challenging, why it is a challenge, the trial was challenged and it's really challenging. What they've asked for this, the Canadian are actually experts. And this has come up from a very small data set, which was actually a negative trial for adjuvant irinotecan infusional IFL. And this is very interesting. This data set of exercise actually came from the IFL data, which was a negative data. And when they looked at the exercise part of it, they looked at it that the exercise group in the IFL only benefited. Although it was not powered to look at it because they had to fill up a questionnaire. And this is how the Canadians picked it up. And what it is actually a 3 years program. Point one. Point two, you had to do a 6 months with a coach. The coach, which is expert, had to train you. The problem is the coach part of it, and that was made mandatory. And the Canadians explained it why in the NEGM paper. The third is that then you do it, and Akash is right in partially that you what they have done is if you look at it per week exercise, you have to do a cycling, which is approximately 1 hour 45 minutes per week, and actually 1.5 hours of brisk exercise or walking. And this included aerobic exercise and resistance training, that is weight training. So this put together was the whole thing, but the most important was the coaching part of it. That is one of the more important part. Why I wanted to make you see this is, if you look at it, we have all adopted the thing of challenge we have to done, and we have, if you see the benefit, which is the health education group and the exercise group, see the benefit, which is a delta of around 7 to 8% of survival. Look at the mosaic, 10 years. It is exactly around the same. So when it's a chemotherapy, we change. When it is not with exercise, we take so much of time, and none of us have discussed this trial. Not even OBTO has discussed this trial. I will tell Amish that this is a trial I think we should discuss. Anand, last thoughts to you, and then Jovita, and then we stop.
No, completely agree with you, sir. I am of 2 points. One, I think the PIK3CA aspirin. I've started testing over the last 1 year. I've not found that 30%, but I
Mhm.
have 3 patients now whom I've put on 150. So
And it's worth it. It's worth it. Test for it. Give that aspirin. You have added survival
yeah,
hours. The
yeah.
PFS
Stage
that
three, I've
matters.
done it. It makes logical sense to me. What also makes logical sense is what I think Dr. Akash and Rakesh have modified the exercise protocol. I think it's a simple thing. We should do it. You're
Yeah.
totally right.
So I was telling you when I was reading and putting the AI and I used the AI, is if it's this, what should be practically, and AI tells me 1.5 hours of brisk exercise, walking and something running in a week, and 1 hour 45 minutes of cycling with weight exercise. That will be sufficient for, as per the challenge protocol. I think that is at least we can tell those patients, and Akash has actually done that when he was speaking of 30 minutes and 30 minutes. Because good job, Akash. So this is where I'll stop. ctDNA is evolving for me. Jovita, any things, because IDR is more traditional. You do a lot of things which is out of the box. Have you thought of starting a structured exercise, or do you think this trial will be read out and IDR will think about it?
So actually, I totally go with you and the study. And added to this, I would add one other thing, sir.
Yeah.
Keeping the diabetes and chronic diseases under control, especially diabetes, because that is kind of a trigger, or diabetes contributes to the uncontrolled malignancy rate in many sites. So I always tell them, if it is uncontrolled sugar, or if they are even borderline, I ask them to change their diet pattern and go for walking and resistance training, and change the diet pattern, cutting out the rice and the carb, and more go for black rice and stuff like that, with a lot of vegetables and higher protein. So that's something which I tell all the patients.
I get it that this is something is beyond medicines, and we should also have to look at the other natural processes. So, to anyone in the panel, want to say something on that 4 or 5 things which we discussed? No. Okay. So to conclude, ctDNA is evolving. It still has a lot of open questions, but I was very interested in that 3 months versus 6 months data. If 3 months you have a ctDNA negative, for the patient who are having toxicity, you can fall back on the data. This is something very, very interesting for me. BRAF mutated frontline was chemotherapy with encorafenib and cetuximab. It's now a done deal. Folfox versus Folfiri. The question is that Folfox, for the reason Anand spoke about, you can just stop oxaliplatin, go with the capecitabine. For Folfiri, that data set is still not there. But if someone wants to start Folfiri, nothing wrong in it. The NOM approach, no benefit of maintenance immunotherapy, that we need to remember, that might again cut short the cost. Please, you need not do immunotherapy just because you are getting a PAP program. That is, you are going to get some late immune-related adverse event, which might be lethal also. Structured exercise post-adjuvant chemotherapy should be adopted. Very clearly, it was a 2025 paper. This year, they read out the cost-benefit analysis as per the Canadian thing. And they found it was beneficial post the first 1 to 2 years. So this is very, very important. The aspirin low dose only for the PIK3 mutated at this point. And I don't know if this data set, which is a much bigger data set, reads out that PIK3 in their subset did not benefit. I don't know how the world is going to react. I don't know about that. But at this point, it is not for all comers, only for those with PIK3 mutations. So this is where I'll stop and hand it back to the organizers. I hope we have added not something to the already what is there in the realm of cancer colon.
Thank you, Dr. Sahu. That was a very nice lecture. And, I was actually telling you today evening that this year we didn't have too many discussions of good papers, but really the way you have discussed for 40 minutes and keeping us all engaged, that's fantastic. Same goes on to just a couple of the papers you discussed. We discussed the whole gamut of HCC. Thank all the panelists over the 2 days. I thank Dr. Karan and Dr. Viraj and Dr. Sendil for agreeing to it. And I have to thank all the organizers, Tarun and his team. They have done this entire webinar pro bono without any charges. So that's something very rare, that we can have a pure academic discussion without any pharma sponsors or anything. So thank you, everyone. And thanks to everyone for tuning and listening. We'll be back next year again. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, everyone. Thank you, Dr. Vamsi, sir. And of course, as you committed, we'll be there next year again in 2027. Thank you. And on behalf of the entire team, good night, stay blessed, stay safe till we meet again. Good night to everyone.